So today we're going to be talking about a bilateral fourth nerve palsy. And the reason you need to know about a bilateral fourth nerve palsy is sometimes it can look like a one side, and then if you do surgery or try and treat the one side, it'll unmask the contralateral, occult bilateral. The features that you should know that suggest a bilateral are kind of the opposite of the features of a typical unilateral fourth nerve palsy. So when we have a unilateral fourth nerve palsy, as you know, the first step is determining which eye is higher. So for this example, we're going to use left hypertropia. The second step is which gaze is the hyper worse. And in a fourth nerve palsy that's unilateral, it would be contralateral gaze. So it'll be a right horizontal gaze makes the deviation worse. And then the tilt, the head tilt will make the deviation worse in left tilt in the left fourth. So it's a left, right, left, like a marching palsy. Left fourth nerve palsy has a left hypertropia, worsened right gaze, and left tilt. And then the fourth step of the three-step test, which is doing a double Maddox rod test to look for the X-cycle torsion that we normally see. So if we just remember the typical features of unilateral, then we can think about when we think about bilateral. So in a bilateral fourth nerve palsy, you have both a right hypertropia and a left hypertropia, and so that might cancel it out in primary position. So you might have no vertical deviation in primary, and that's going to be very deceiving because the person looking straight ahead might be straight. And as opposed to a left hypertropia and right gaze, or a right hypertropia and left gaze, depending on which side the palsy is on, you will have a right hypertropia in left gaze and a left hypertropia in right gaze in a patient who has a bilateral fourth, and that type of reversing hypertropia cannot occur in a unilateral fourth nerve palsy. And the same thing with the tilt test. So if we have a left hypertropia worsened, left tilt, and you have right hypertropia and right tilt, that's also suggested that you have a reversing hypertropia that might suggest that this patient actually has a fourth nerve palsy that's bilateral rather than unilateral. And then the double Maddox rod testing, normally we're going to allow a single digit kind of number for the X-cycle torsion in a unilateral, but in a bilateral fourth you might have a big number like a 12 or a 14 that's bilateral X-cycle torsion. In addition, on adductions and inversions, we might see bilateral underaction of the superior oblique or bilateral overaction of the inferior oblique in a patient who has a bilateral fourth nerve palsy. So every patient with a fourth nerve palsy, we're going to be thinking about the possibility that there is an underlying masked bilateral fourth nerve palsy. We're going to do the three-step test, but if we see something funny on the three-step test, either no deviation in primary vertically, or reversing hypertropia in right and left gaze, or a reversing hypertropia in right and left head tilt, that kind of reversal of the hypertropia cannot occur in a unilateral fourth nerve palsy. We're going to do the double Maddox rod testing looking for the X-cycle torsion, and if we have big double-digit kind of numbers of X-cycle torsion, we're going to think about bilateral fourth, as well as looking on the adductions and the versions for bilateral underaction of the superior oblique and bilateral overaction of the inferior oblique in a patient who might have a bilateral fourth nerve palsy.